My name is Scott Celinski. I'm a surgical oncologist and hepatobiliary surgeon at Baylor University Medical Center in Dallas. So, are there strategies that we can use to increase the likelihood that patients with colorectal liver metastases that are initially deemed to be unresectable to get them to resectability? So the answer is yes, we do have strategies that can take initially unresectable disease and turn it into resectable disease. And when we talk about unresectability, generally we're talking about in order to get out the tumors in the liver, we're not going to be able to leave behind a remnant of liver that can keep the patient alive while the liver regenerates. We refer to this portion of the liver being left behind as the future liver remnant. And it needs to be, we all know from medical school that the liver regenerates very well. You only need about 25% of a normal functioning liver to do just fine. And if you have that amount, then we can have that hypertrophy and it actually regenerates to about the same size as what was initially taken out. So in order to keep that liver alive, we need to have adequate functional liver. So approximately 20 to 25% of hepatocytes. We need to have vascular inflow. So we need portal and hepatic arterial inflow. We need to have vascular outflow through the hepatic veins, and then we need to have biliary drainage. And so if we're not able to accomplish that and get out all of the tumor with a designed operation, then our future liver remnant is inadequate, and we need to come up with strategies to take this patient from unresectable to resectable. And when I think about this, basically I think of we either need to shrink the tumor down so that we don't have to take out as much liver, or we need to grow the liver so that we have the ability to leave behind more. And generally when we look at shrinking the tumor, that's going to be systemic therapy. Can we shrink it away from the important structures and get to the point where we can leave behind enough liver? Additionally, we can look at local therapies, sometimes radiation or Y90, or things like transarterial chemoembolization, also called TACE, in order to accomplish this. It is important for us to remember the hepatotoxicity of the treatments. Our main current systemic therapies involve irinotecan or oxaliplatin, both of which have liver toxicity at prolonged administration. So generally we look at trying to limit the chemotherapy to about 6 cycles or 3 months before we look at doing some sort of resection. When we look at the other side of growing the liver, we've got multiple strategies for this. The first one is portal vein embolization, which is where the interventional radiologist goes in and includes the portal vein to the side of the liver that's going to be getting taken out. By decreasing that portal flow, it does 2 things. It causes atrophy of the side of the liver that has been embolized, and it causes hypertrophy of the side that's going to stay in. Generally, we do a portal vein embolization followed by 6 week waiting period before we re-image to see if we have had adequate hypertrophy. Some downsides to this are that if you have disease in both lobes, that hypertrophy of the liver can sometimes result in hypertrophy of the tumors in that side also. So additional strategies would be a 2-stage operation, where the first operation we go in and we clear out disease in the side of the liver that's going to be left behind, followed by portal vein embolization, which can avoid that risk of hypertrophy of the tumors inside the future liver remnant. Problems with this end up being that sometimes we don't have that growth in the second stage of the operation to be able to complete doing this resection. And so more recently, a new technique that's been dubbed ALPS, which stands for Associating Liver Partition with Portal Vein Ligation for Staged Hepatectomy, basically is an accelerated 2-stage operation. The first stage, we go in and we clear out the future liver remnant of any disease. And then at that same time, we ligate the portal vein to the side that's going to be taken out down the road and divide the liver to remove any collateralization, which decreases the chances of hypertrophy, or decreases the chances of lack of hypertrophy of the future liver remnant. And so now, instead of having to wait about 6 weeks before we have adequate hypertrophy, it generally only takes about a week before the future liver remnant has grown enough for us to be able to go in and complete the second stage. This has the advantage of a significantly higher rate of resection, but does come at a little bit of a cost of morbidity and mortality. But we have been improving with further experience with this technique. So we do definitely have strategies in order to take patients who are unresectable and turn them into resectable when it comes to colorectal liver mets.